Hello, welcome to Snippets at SABCS. It's my pleasure to introduce you to Dr. Jean Wright, who just gave a fantastic presentation about DCIS. Jean, tell us about your study.
Thank you so much, Dr. Zellars, for the opportunity to talk about this study. This study was actually a combined analysis from two separate cooperative group studies. So the first thing is it was just a great collaborative effort between ECOG-ACRIN and NRG RTOG. We combined data from the RTOG 9804 study, which was a randomized trial looking at the impact of radiation therapy on ipsilateral breast recurrence in a cohort of patients that were identified as having good risk DCIS, which means DCIS that measured less than 2.5 centimeters in size, was grade 1 or 2, and had margin width of 3 millimeters or greater. The ECOG-5194 study was an observational prospective study of patients who had breast-conserving surgery but did not have radiation therapy. So we combined the group of patients from the RTOG study with good risk DCIS who had not had radiation therapy, and then looked at a cohort from the ECOG study, also who had not had radiation therapy and had the same clinical and pathological features. So we looked at these two groups of patients together and evaluated the impact of tamoxifen on ipsilateral breast events in the combined data set. Interestingly, tamoxifen was left at the discretion of the treating physician and the patient in those two studies. So the utilization of tamoxifen was a little bit different in the two studies, but overall we had about half patients receiving tamoxifen and the other half not.
Excellent. And what did you find?
So the analysis showed that tamoxifen reduced the risk of an ipsilateral breast recurrence by about half, from about 19% to 11.4%, 15 years after diagnosis. So this is long-term follow-up showing a significant reduction in ipsilateral breast events with the addition of tamoxifen. The other really interesting thing was that there was a statistically significant improvement in invasive ipsilateral breast events, but actually a not significantly different rate in DCIS recurrences, so suggesting that the tamoxifen really has a greater impact on preventing invasive recurrences, more so than DCIS recurrences.
Wow, this is really important information. Tell me, how will you use this to counsel your patients moving forward?
Well, I think that what we're doing today in sort of research in early stage or DCIS, kind of low risk breast cancer diagnoses, is trying to increase the menu of options that a patient has when they're facing this type of diagnosis. There are a lot of reasons why a patient might have a preference for one form of therapy or another. So we've identified with 9804 this group of patients who could reasonably choose to have or not have radiation therapy. If they choose not to have radiation therapy, then it's important for them to be able to understand what would be the impact of their decision about endocrine therapy. So the first thing is we now have really clear statistics that we can provide to those patients. And we can tell them that actually when you compare the risk of a in-breast recurrence in the radiation arm from 9804, that was about a 7% risk at 15 years. And then with tamoxifen alone, it was 11.4%. So you have actually, relatively similar in-breast recurrence risks between the two options. So patients can weigh their preferences in terms of, the toxicities and, duration of therapy and all the other considerations that they would want to consider.
What I find really very interesting, a couple of things. One, that this was done at a time before we really understood, I think, fully about the lack of consistent tamoxifen taking by the patients. How do you think that influences your results?
Yeah, so I think, the first thing is just that it really shows like the utilization of tamoxifen was so different in the two studies. It shows just how variable our practice has been. And I think just the fact that the studies have really focused on radiation therapy and not really, specified how tamoxifen needs to be used. But I think that now that we're seeing that there really is a measurable impact on invasive recurrence, I'm hoping that we can also include looking at, endocrine therapy utilization when we look at future studies focusing on DCIS. I think the next generation of studies looking at DCIS will be focusing on these genomic assays that are available, whether it's the Oncotype DCIS score or the Decision RT, both of which are assays that can hopefully help us make decisions about which patients would benefit most from radiation therapy. But I think if we set these studies up in the future, we should think about how to stratify them so that we can also evaluate the impact of endocrine therapy so that we can get a little bit more standardization going forward.
That was my question about your future approach. I love it. Before we quit, I just want to thank you for doing that. I think it's great that you sort of repurposed the data. 2 different studies, you combine them, which I know is not easy, and to get such a great results. I hope you're setting up a model for future.
Absolutely, and we are hoping to continue the collaboration. And I also think this is a great moment for me to just acknowledge and thank Dr. Larry Solin, who actually was the person who initially led the ECOG study before my time. And even though he passed away in 2020, his vision from the very outset was that we might be able to combine these 2 data sets. So I think this is, an excellent, marker of his legacy, and also just showcasing like what we can accomplish with cooperative groups working together.
And I want to underscore that the fact that you mentioned him at your presentation was beautiful. I want to thank you.
Great. I'm so glad I was able to do that.
Thank you so much for joining us.
Absolutely.
It has been a pleasure.
Thank you
Enjoy
so
the
much.
rest of the meeting.
Thank you. You too.